All right, thank you all for having me. It's the first time I'm joining NCAN. It's a pretty interesting meeting, and thanks for the invitation. I am one of the gastrointestinal oncologists. I work at Washington University in St. Louis. I actually came from community oncology. I did 3 years, and then in 2017 I joined. So I have a completely different story from Dr. Lowell. I actually had to learn how to see patients and treat patients with neuroendocrine neoplasms, and that's why I think I'm one of the people that can tell you about the importance of having a multidisciplinary team for the management of patients like that. And also, disclaimer, I don't have very busy slides. I talk a lot, I have an accent, which is the bad thing. The good thing is I did not stay late, so I'm pretty fresh today. So let's see. This is Seidman. This is Washington University in St. Louis. As I said, I come from there. I'm an assistant professor, and I see patients with gastrointestinal malignancies. Actually, when I first joined, I joined having trained as a brain tumor specialist. So my boss then said, I don't need any brain tumor specialists. We need someone to see patients with gastrointestinal tumors. I said, fine, I'll do that. Very soon, I realized that there's a very large group of patients that actually are very interesting for reasons that I'll explain in a little bit. So these are my conflicts of interest. I'm not getting paid. I don't have advisory boards. I do function as the principal investigator for clinical trials. They're pharma-based, but that money, goes to the institution, not me, although it appears under my name. So objectives. The things we want to look at is, number one, why are people with neuroendocrine neoplasms so sensitive? Why do they require care maybe a little bit more than other patients on whom we have a lot more of knowledge about their disease course, about the outcomes and the treatment efficacy? And the other thing I want to highlight is how important it is to have different members that can actually help you guide patients during that path. And then a little bit about the knowledge behind multi-D team effectiveness, which we'll go over in a second. So you've seen this many times before. This is a very simplified concept. It's what neuroendocrine neoplasms look like. I consider the whole neuroendocrine system just a system of little cells that respond to hormones, work with hormones, and try to modulate other cells. And I consider them a fine, lace-like pattern in the whole of the body, but occasionally you have those lumps of big organs like your thyroid, your adrenal glands, which have very specific endocrine functions. But you can get a cancer anywhere in that. I usually focus on people with gastrointestinal tumors, and this is the bulk of my work so far. You've seen this a lot of times. This is probably one of my favorite slides. It's a paper I saw when I first joined. It was 2017 by Dasari. I'm a fan of that. I've never met him, but I like him a lot. So I keep showing that to our patients to just explain. Just explain that people with neuroendocrine neoplasms do not have a rare tumor anymore. The prevalence the incidence is low. Very few people will get diagnosed. And before I joined academia, I probably saw 2-3 patients every 6 months, and now I see 2-3 patients every clinic day, new patients. And the thing is that the understanding of who has neuroendocrine neoplasms is rising over time. More and more people get diagnosed or properly assigned the neuroendocrine term. And when you look at subcategories, you've seen that many times before. Certain people will have more, a rising incidence of neuroendocrine neoplasms. We don't know why, but people live a long time with this disease, or can live a long time with this disease. So your patients, even when they're metastatic, or your friends, or you yourself, this can go on for years. The longest I've seen is people in their 20th or 30th year with that disease. So over time they accumulate. So this is not really a very rare disease anymore. So one of the first things I told my boss again is, we probably need a specialized clinic for patients with neuroendocrine neoplasms. It's a big institution. It's not as rare as you think. We will have those patients. I know, it took a little bit of convincing. He said, I don't need that. But in any case, he got convinced. And a few things that I showed him to convince him was the actual guidelines that are evolving for the treatment of patients with neuroendocrine neoplasm. So this is, these are the National Comprehensive Cancer Network guidelines. So a lot of institutions in the country, WASH is one of those, they gather every 6 months, every 3 months on occasion, and they review the available evidence and they create those pathways. They try to tell the world or the U.S. Depends on how you view the world. That certain pathways are better than others. That you should prioritize certain treatments over the others. When I first started, those guidelines were not that extensive. There were a few. Probably 60 to 70 pages. This is the latest iteration, 185 pages. So it's a lot of work, it's a lot of knowledge, and that reflects how complex those tumors are and how complex the knowledge behind those are. Now, obviously, things get a little bit more weird. When you look at the subcategories, again, we're talking about the same guidelines. You see that even though we say neuroendocrine tumors, you have all those subcategories. Pancreas, unknown primary, grade 1, 2, 3. These are confusing, but all this adds to the argument that this is a disease that shouldn't be taken lightly, and people can present with different shades, different aggressiveness. We'll go over in a second. What we also found out is that not just the tumors themselves, the patients with the tumors themselves, but also the treatments that we have are a little bit difficult to prioritize. So this is a part, again, from the neuroendocrine guidelines, from the pancreatic part, where you see, an array of options. All of these are options, and in between, I'm not sure if you can see, it says or. And very few of those have what we say, category 1 designation, which means there's a lot of knowledge behind it, kind of know how it works, and we can still not prioritize one treatment over the other. So definitely a complex disease, and definitely, appearing many different ways. The treatments are also pretty complex, and even the bigger institutions in the country, I'm not saying they're the best, just the bigger institutions in the country, they're not pretty sure which treatment should go first. This is an area of active discussion. So this is when I made the argument for a multidisciplinary team, and I tried to explain to my boss that we need a dedicated team, we need a bunch of people that actually know what they're doing, and quite sincerely, I kind of hope that people would, help me understand more during, this pathway. 6-7 years later, I can say that we know what we're doing, but it was a process. So, multidisciplinary team is basically the medical oncology people. I don't think they're the more important part. It's just that I'm giving the talk, so I'm starting with that. So, patient and circle of support, which I think is pretty important, and then you have, your surgical oncology team, your pathologies that we kind of join in at the beginning and maybe join again in the future. You have your research coordinators and your trial people. You have your nuclear medicine team and your interventional radiology team, your radiation oncology team, very big players, especially with the use of Lutathera. And then nutrition psychology, genetic specialists, endocrinology. These are all very important contributors to the treatment of a patient with a neuroendocrine neoplasm. Now, all of these kind of interact with each other. So it gets a little bit confusing. All I'm going to try to explain now is why I think each and every one of them is pretty important. We're not going to talk about all of them. There's not enough time. So we're just going to focus on a few of them. Again, no offense to endocrinology. These are pretty important specialties. So pathology. A pathologist is pretty much the person who will break the good or bad news. And in people with neuroendocrine neoplasms is the patient, the person that will go over, your biopsy and tell you whether there's, an aggressive tumor, a tumor, or a neuroendocrine tumor to begin with. You've seen that picture before. When I first joined, to be honest, I had no idea why people had so many different names for neuroendocrine tumors. There was the carcinoid, which is a beautiful Greek word. I'm Greek, and said that it's like a tumor, but it's not really a tumor. It's like a fake tumor. And then we had the neuroendocrine tumor, which I kind of understood. It's a tumor. And then we had the neuroendocrine carcinoma, which was supposed to be a fast-growing tumor, an aggressive tumor, but also meant that sometimes it was a tumor that was outside the original area, so we assumed it was aggressive, even though it was not aggressive. Then we had the benign neuroendocrine tumors, which were horrible to deal with because insurance companies would say, that's a benign tumor, I'm not authorizing treatment. Then we have gastrinomas, lipomas, insulinomas, islet tumors, which are the pancreas-related tumors that produce a significant hormone, very rare tumors, and we just get a different name. And then we have the mixed neuroendocrine and non-neuroendocrine tumors, and then we have the collision tumors, which are like mixed neuroendocrine tumors, but they're not really, hitting each other, that next to each other. And then we have the adenoneuroendocrine carcinomas, which is head and neck tumors that really have a neuroendocrine component. They don't have adenocarcinoma component, but we just kept talking about them this way. And then we had patients who didn't really have neuroendocrine tumors. They just said they have a neuroendocrine differentiation. We threw a stain on them and kind of looks like they could be neuroendocrine, so here they come to your clinic. And they did not have a neuroendocrine tumor, and they don't have anything that people have named carcinoid in the past. So carcinoid just meant slow growing, we're not sure that's a tumor, and that kind of encompasses mainly patients with the old type neuroendocrine tumors, but really any type of slow growing tumor. So people were sending us carcinoid tumors of the gallbladder, which were just regular cancers. They were not neuroendocrine tumors. So I think this slide may explain why a good pathologist is very important to you. I always ask them, these are my best friends, these are the people that I get to meet whenever I go into an institution, and I ask them, what do you think is happening and how aggressive do we feel something is? Talking about aggressiveness, you've seen this before. This is the bar that essentially shows whether someone has a very low-grade disease, slow-growing disease, the carcinomas that we're talking about, or a very aggressive disease, the high-grade disease, the very dangerous variants of that. So your pathologist helps in certain ways. They can tell you if the tumor looks well differentiated, so kind of more organized, better behaving, hopefully, or, and these are the neuroendocrine tumors that we used to call, or whether they're poorly differentiated, and these are the neuroendocrine carcinomas. I call everything neuroendocrine neoplasm now, just know the differentiation. And then there's the proliferation markers that everybody keeps talking about. We keep arguing whether we call it Ki67 or K67. But anyway, it's proliferation markers that tell you whether the tumor is growing fast, or they're in the intermediate category, or whether you should be really worried because they have a high-grade disease. So that's where NET G1, G2, G3, at least for the bowel and neuroendocrine tumors comes into play. There are a few other subcategories. So your pathologist can tell you where exactly that neoplasm fits. So whenever someone comes from as a second opinion and they say, oh, they have a carcinoma, that means nothing for us. We need to know how aggressive, what category, how well differentiated they are. Why? Because it plays a big role in our treatment categories and treatment options. So people, that's where medical oncology comes in. So people with low-grade disease, the slower-growing tumors that are pro-hormone producing, you might choose somatostatin analogs, your octreotide, your lanreotide. These are important treatments. People with a little bit, higher grade disease may choose different treatments. If those people don't do well with somatostatin analogs, you consider your PRRT or your small molecules, your everolimus. Again, if you look, these are, usually people in the better behaving categories. But when you go down here, when you have high grade disease, then chemotherapy works. I cannot stress how important it is to not use one in place of the other. So somatostatin analogs for someone who has very aggressive disease probably won't work. It's a waste of time. The disease will grow. People will get in trouble. Same as chemotherapy in people who have very low-grade disease. It just won't work. Most chemotherapies, affect tumors that are growing fast. They affect division. So if you give it there, you're in trouble. So when I was starting the clinic, we did get, thankfully, fewer and fewer lately patients from the, the community, other physicians, or, I'm guilty of that. When I was a community oncologist, I got overexcited with certain patients who got chemotherapy for low-grade disease just because it was bulky, had grown all over the body over, say, 5, 6, 10 years, and people just got scared and just slammed those patients with chemotherapy. Then they got excited because the disease was not growing and told them, it's a tough chemotherapy, but look at it, it's not growing. So those patients did not need chemotherapy, and quite conversely, some people were diagnosed with a higher type of disease, and they were told, well, it's a benign tumor, we'll just give you some injections, and those people got in trouble very early. So again, if I haven't convinced you with that about how important pathology is, I don't know what to tell you. I hound them all the time. We've published with them. They're really good people. We actually went back on our own institution and took a look at what we do. So we looked at mischaracterization, which is a tough subject. How many times do we consider someone to have a low-grade disease and they have a high-grade disease or maybe intermediate-grade disease, and how much do these overlap? Thankfully, no major mischaracterizations, but about 15, 20% on occasion, grade 2 disease was actually grade 1 disease and vice versa. Would that have a major impact on patients' survival and their treatment outcomes? Probably not, but this would. So these are people who actually did not have cancers that are neuroendocrine. These people had sarcomas. So Ewing sarcoma and a certain type of small cell round tumor, I don't even remember what it's called. I don't treat sarcoma patients, and I shouldn't because I really don't know how to do with them. Ewing sarcoma is a highly treatable cancer, especially when you have a localized disease, but on occasion those patients will have neuroendocrine markers. If your pathologist is not really subspecialized, they may end up mischaracterizing them. So these are very rare tumors, thankfully, but we looked at 10 years passed in our institution, and we saw mistakes that were made even by us. So I cannot stress how important it is to get the right diagnosis and get it up front. That helps us understand, where to go. So here's surgery. I hate talking about the importance of surgery because the surgeons already feel extremely important. But it's true, they have a reason to feel very important, and quite frankly, they are important because, as I tell our patients, we're really good at controlling the disease from medical oncology and radiation oncology, but the only curative option for now remains surgery, whether it's surgery up front or surgery after you've had some considerable response and just take out the leftover, tumor. These are the only people who have the potential to cure, patients for now. Doesn't mean that everybody has to have surgery, and this is where I'm getting now. This is again the same paper. I sound like a fun boy, fun girl. So anyway, this is by Dasari. It's the same paper that I like, and actually looks at SEER data. This data has been replicated in other studies. It's actually very old data. So UK and also Thor Hafdanarsson from Mayo has done the same thing. Essentially, it looks at people with localized disease and distant disease, regional disease. So the black line here is localized disease. Localized disease is disease that probably was resected. We assume that most of that was. And you look at the survivals. All of these are survivals. These are months. So we're talking about 20 plus years here. So people with localized disease from the appendix, for example, they live a very long time. Rectum, a very long time. So a surgeon or the endoscopy, someone who removes the tumor, can actually, infer cure in certain circumstances. And when you have, widespread disease, cure cannot happen. You can still have very good survivals, depending on, the other categories of the tumor, but surgery is very important. Well, if surgery is important, why doesn't everybody have surgery? What do you need to have a multidisciplinary team? Just send everybody to a surgeon. Well, it's not always necessary. So every year at the big conferences, since I started joining in 2017, there's a fight with the surgeons and the medical oncologists. The surgeons say we should remove as much of the tumor as possible, and medical oncologists said maybe not. And then data here, data there. It's a friendly banter. This is a friendly group, but definitely we haven't made up our minds on how much is too much. But I'll show you one case where maybe surgery should not be that excessive, and that's appendiceal neuroendocrine neoplasm patients. So appendix is a very rare tumor site for neuroendocrine neoplasm. People find out that there's a tumor there because they had appendicitis, they had appendiculitis, they got removed, which is fine. But when you find a cancer in the colon, everybody gets shocked. And the instinctive response is go back in and remove the rest of the colon, at least half of it. And one could say, you want to be sure, and a lot of those patients are very young. The youngest I've seen, I think, 16 or 14. So you don't really leave a tumor there and have someone die many years later, even if it's a slow-growing tumor. But what we found out over time is that, the survivals are the same, whether the tumor is just, localized or whether some of the lymph nodes are involved. What does that translate to? Very loosely, it could translate to the fact that, hey, if you remove the little tumor with appendectomy, which is a small surgery, maybe we just wait if it's small enough before you figure out whether you want to remove the whole right bowel. Removing the right bowel is pretty debilitating, and over time we realize that most of the times we're removing it, and there was no tumor there, and most of the times that reconnection made people have terrible diarrhea. So a surgeon, an expert surgeon, will be able to tell you, that sometimes, surgery or excessive surgery is not enough, and that's a very difficult thing to get out of your mind. Most of the times, and even now from the community, we get young people who are offered a right hemicolectomy, removal of the right colon, and we say, well, let's talk with the surgeons, but probably that doesn't need to happen right now, because even if at some point in the future you end up having some lymph nodes that are positive, we can remove them. You live the same amount of time, most probably. Again, they didn't live 350, 360 months. It just means that we stopped checking. These people are probably cured. So surgeons are important, and gonna leave it there. So we're gonna go to imaging, radiology, and nuclear medicine. You've probably seen, the reports, nuclear medicine reports like your Dotatate scans, which, one of them is here, your FDG scans. And you have your regular X-rays, your CTs, which I think are pretty good starting point. Why are people who read your scans very important? Why should they be specialized in neuroendocrine tumor cases? Well, because these are, as we said, on occasion very slow-growing tumors. So you need to get out of the mindset of regular cancer. So whenever you do a scan on a patient with a colon cancer and it shows slight progression, you get worried. You need to switch treatments before things get even worse. But in people with neuroendocrine neoplasm, a little progression, a few millimeters every year, that doesn't make a difference. That's not even important for most of those people. You can keep treating with the same treatment and then wait for some more significant progression before you actually end up changing your modalities, which there are a lot of them. And more importantly, I used to get those scans. Thankfully, I don't get them anymore, saying there was treatment failure. Treatment is not working because the tumor is as much as it was, 2 months ago or 3 months ago. And that's, you guys have access now to your medical files. You can see those results before we see them. And people were getting anxious. Say, what does it mean that the treatment is failing? It's not failing. Stability is the goal for a lot of people who get, injections. We've seen people stable for more than 10 years. That's actually a good thing. It's not a treatment failure. So we need to get those people out of that mindset. Now, those reports don't come anymore, but there are people who just don't understand when something is really growing, when something is slightly responsive to therapy, and they get all those weird reports that we end up, re-examining sometimes in a tumor board. What's even more cool about, being in a big place that has a lot of smart people is that you can, ask people who do the newest and brightest and best scans. That's, for example, the Dotatate scans. Now we have copper-based scans, which are slightly different than other ones, and everybody's learning about how important they are. It's also cool to have people that actually can tell you from the scans what the tumor is looking like. So this is Motoyo Yano. She was one of my colleagues, a radiologist. She left us for Mayo, Arizona. Anyway, so she's really good, and that's why she left. So, but she did a study where she realized that she could actually figure out whether a tumor was fast-growing, slow-growing, or whether it had a bad behavior just by CT imaging alone. She was able to show it in a study. These are things that you cannot easily get from someone whose job is to read any kind of CT scan for any kind of cancer, any kind of broken bones, not because they're dumb or they just don't know what they're doing. It's because once you sub-specialize in a certain category, you become the best at it. I mean, if I teach you how to, I don't know, perfectly warm a toaster strudel over 20 years, you will become the best in the world because you will sub-specialize in that. That doesn't mean you're the best cook in the world. It just means you're the best at warming a toaster strudel. So the other thing with imaging that's very important is that sometimes we do too much of that. So these are nice criteria by Hope, Tom Hope at the Journal of Nuclear Medicine. We probably overuse Dotatate scans, and we shouldn't be using them too much because a lot of times they add to the anxiety more than actually help us understand where the tumor is going. Fun fact, Dotatate scans were around summer of 2016. By the time I came to WashU, we were using them very little, then we used them a lot, and then the community took them about 2 years later, and that's when the weird results started coming in because people were just not used to them. They didn't know what to do with them. So it's useful to have someone who knows, and this is obviously a collaborative effort from many institutions that actually led to certain guidelines about not to overdo things. Interventional radiology, very few things about it. Your interventional radiologists are the people who will just target your liver, usually, and just stop the disease from growing in cases where the disease is just growing in one area. And that's pretty good because some people just have very localized disease, and the disease is only progressing in one area of the body. So you can do that, and you can spare yourself from more expensive treatments, more intense treatments, pills and radiation therapy and all of that. We have great interventional radiologists. Some of those have left us, not for Mayo. So, but some of them are back here. They're actually pretty good at targeting certain lesions. They're good at debulking, taking care of the biggest lesions that may be causing a hormone hypersecretion syndrome, and those people actually make a difference. What is more important with those people, they know when not to do it, when it's dangerous, when the liver is going to be affected, and they know which agents to prefer. For example, certain radiation treatments of the liver can have long-term effects on the liver. Long-term means 2 to 3 years, and we don't mind for people who have very aggressive cancers, but for someone who's going to live maybe 5, 10, 15 years, it's a very big deal, so you should be planning ahead. So an interventional radiologist that knows what they're doing, pretty important. And then the radiation oncologist, probably the biggest player since 2018 when PRRT was approved. Before that, radiation was just shooting certain parts of the body, make sure the pain goes away or that certain areas are controlled. PRRT was a learning curve for us. So PRRT joined, was approved about 6 months after I joined the institution, and it was a game changer. We had to learn how to use it. There were a few of our seniors who had used it before in clinical trials, some others from Europe, but in general, most of us just didn't do a whole lot of it. Appropriate use of PRRT is very controversial. It's a treatment that works very well when it works very well, just almost spectacularly, but sometimes it doesn't, and sometimes you shouldn't be using it first because it can have some long-term effects. Over time, we figure out, again in a multidisciplinary team, that some people who get PRRT may have abnormal blood tests, their potassium may go up, and that's a bad thing, It's a lethal injection used to be, potassium chloride in the old time. So it's a very big deal. Not everybody has that happen. Actually, it's a very rare phenomenon. But we identified that and just did a whole work on it, reviewed the literature, and created our algorithm. So that would not have been picked up if I was, functioning without a team. If no one had called me and said, "Hey, this patient is getting this treatment, and this is what happened." If we're not communicating with each other. More importantly, and that is. That's a busy slide, but I'll explain in a second. PRRT can have some long-term effects. Long-term effects include myelodysplasia, blood disorders. And this may not be a big deal for someone who's supposed to live, or hopefully will live more than that. But if they're going to live a few years only, it's fine. If they're going to live, again, 10, 15 years, a big deal, because once you get the myelodysplasia, I'll isolate the area of myelodysplasia. This is a paper from Mayo, Thorhart-Darson. When you isolate the incidence of myelodysplasia, we don't really know how often that happens. You see, different studies claiming 0% to 20% to 3%. But when that happens, it's a very big deal. People with myelodysplasia don't live a very long time. And so you need to be very careful about who to treat and when to treat them. That's where the input from the radiation oncology team is pretty important. And then it's us. I have to justify my salary somehow. So, most of the times, medical oncology just plays the traffic warden. We just direct people, get input, present patients, and we see them most of the time. So we take care. We take over. This is just a diagram that shows you we basically have like 3 treatments, maybe 4 treatments, and that's how we basically look at people who have disease, how we treat them over the course of their disease. What I want to focus on is here the neuroendocrine tumor board, the targeted treatments, and the clinical trials that we're very much in favor of. Why is medical oncology important? Number one, with the traffic warden, as I said, we make sure that people see the appropriate specialists, get discussed at tumor board, and also we need to know when we're doing too much. So people can have very good responses to therapy, and one of the therapies that we use is capecitabine and temozolomide for pancreatic neuroendocrine neoplasms. It works well, but we don't know where to stop. And more importantly, one of those drugs can cause myelodysplasia and leukemia, the same way PRRT can do it, many years later. So we just did our own study, looked at the literature, and tried to find out when people develop leukemias. The leukemia event is that unfortunate little orange circle, and this is time, over time, and this is cumulative toxicity. So how much treatment you're getting goes up the more treatment you get, and how much time goes by, the more to the right you are, it's more time goes by. So you see a cluster here around 1 year, a specific amount of treatment that tells you, or at least tells us, this is when you should be probably stopping treatment. More importantly, because some of those patients will do well even when you stop the treatment. They'll just ride a wave when they have good response, and they won't need any treatment sometimes for years. So overdoing it is a big deal for anybody, for the surgeons, and fortunately for the medical oncologists, and for the radiation people, and obviously for everybody else. So with all that in mind, I'll reshuffle a little bit the multi-D, and I'll say that, patients in the center, obviously, your wishes are the most important thing, the wish of your family. But we try to move things around and make sure that this is important. So when I realized that we kind of need this theme, I went to my boss and I said, well, we need a tumor board. And he's like, I don't need a tumor board. We have a lot of tumor boards. So, well, no, we need a neuroendocrine tumor board, because this is a very, this is a very unusual tumor. She was, over time he got more receptive to the idea. I mean, he pushed back and I said, no, we need it. So we got it. And the reason behind that is that I tried to make sure that things are more organized. Is there any knowledge that having a lot of people talking together at the same time is useful? There's indirect evidence. So what is the indirect evidence? Oops. Oh, here you go. So this is, again, this is the NCCN panel. These are not the best institutions in the country. They're just some of the largest ones. There are many other very good institutions. And, there's a ton of specialists in the country, which some of those are here today. I mean, some others I know specifically. This is not geographically appropriate. This is not where Mayo is. This is not Minnesota. But anyway, you get the point. There's a lot of people, and this is us, shameless plug. So there's a lot of institutions in the country that function as, for me, as a gigantic tumor board. That's how guidelines are made. That's how multi-institutional trials are made. These are a lot of brains, very, very important brains, just work together. And I kind of wanted a microcosm of that, in my own practice, and that's what we did. This is a multi-D tumor board. It's not as big now. I mean, she's left, he's left, she's left. I mean, they've gone to better institutions. It's not like we chase them away. They have better positions, and we function together. But these are people who actually were very happy to participate in a multidisciplinary discussion and bounce ideas off each other. I know some of them don't look as happy, but there is just some people don't. She's the sweetest person, and but they don't photograph well. So is there an importance for the tumor board? So I didn't know that. So there is knowledge that tumor boards enhance patient satisfaction. Fine. There is knowledge that treatment decisions change with tumor boards, and there's data that's come out in a lot of different cancers. We've never really been able to show that the outcomes are that better, because we're going to get a lot of other treatments, but I still wanted to know what's happening with the neuroendocrine world. So there was a very good paper for James Howe in Iowa for endocrine tumors, so mainly how can I say, the thyroid and maybe adrenal, if I remember correctly. But I want to see what's happening with us. So I just, went back and got all of our recommendations and looked at all the tumor board outcomes. We weren't able to follow patients, prospectively. However, we saw that major treatment decisions, happen pretty much all the time. About 20% of the time, or 30% of the time, the radiology report just changed. There was no progression, or there was progression, something different from what was brought onto our tumor board. And granted, these were people that were brought there because, we had a suspicion there's something going on. If you go to don't know, if you go to a private detective because your partner is stealing money from you, you suspect that they're stealing money from you, most of the times they'll find that they do. But that doesn't mean that most people steal money from the partners. It means that you bring the attention to the detective because you're worried about it. Same with the tumor board. Most of the people that were brought there, we had questions about what is happening to them. So I don't think that everybody needs to be on a tumor board, but it definitely made a difference. It made a difference in a different way as well. I told you, PRRT got approved right after I joined. So 2018, I didn't know what to do with it. I had to ask people. I had to ask Thor. I had to ask, Dr. Chohan, people from other institutions. But I also had to ask the people at the tumor board. And these are the recommendations over quarters. As you see, when it first came out, first of all, we didn't know what to do with it. And then, as we started making decisions on more and more people, we just discussed them at the Multidisciplinary Tumor Board. And over time, when we knew what's going on, when the data came out, we just quieted down. So this collective, group of brains actually helped us understand how to, safely administer a new treatment based on the data that was already there, that we knew about, but also the lack of experience that, we didn't have at the beginning. Now we're experienced, but, it took a while. So does that mean that you should always come to a major institution? Do you have to, go to one of the major centers and have your cases reviewed and verified? I don't know. I don't know this answer. One of my best friends is an interventional radiologist for stroke. He's a neurologist, and he's excellent on that. And I watched him, review patients, write down all the different parts of the exam, and then, after 2 hours of designing, saying, I will give you an aspirin. I was like, I could have done that on my own. I mean, it's not a big deal to give an aspirin to a patient. He said, yeah, but the thought process behind that is what matters. The actual application of the treatment doesn't matter. That's why he gets, the good money. Same with us. Most of our recommendations may be repeat a scan until something happens, or, take your injections, or, try the everolimus and call us if something happens. So you don't really need to be here. I was a community oncologist. I didn't become smarter because I came to academia, just hyper-focused. So community oncology physicians are wonderful. They can do a great job. I would advise, maybe once in your life, just have your case reviewed by, a higher institution, especially pathology and, surgery. Why not? Go with the surgeons. But it's good to at least get an opinion somewhere. If you feel that something is wrong from the get-go, if you were promised that the disease is going to respond, it's not responding, something's going really bad, then I say come and see us, or anybody much sooner, because you cannot supplement experience. It's very weird. So I think this is the last one. So this is St. Louis. Again, I'm reminding you, I'm from St. Louis. This is the zoo in St. Louis, and these are the zebras that I took a picture, so I don't have to claim copyright. Very interesting formation. I found that fascinating. They're not friendly. I try to pet one. We try to adopt one, but it's not. I wonder, or not, we won't have an event. So anyway, they all stand next to each other, actually behind each other, so they kind of keep an eye on each other's backs, and they're all, looking forward. Well, the last one is in trouble, but that's the corner, so he's actually very safe. And that kind of reminds me, how we move ahead, both people who research this problem and the patients themselves, always looking out for each other and actually just looking ahead. I think there's a good amount of things that are coming in the future, but for now we kind of have to bounce off each other's ideas, and I think that's it. I think that there's a Twitter handle. I don't know how long that's gonna be around because there's a lot of problems going on there, but feel free to contact us if you need anything.